Welcome back to another ATLS Explainer. Today, we are diving deep into what is, without a doubt, the absolute cornerstone of trauma resuscitation, Chapter 4, Airway Assessment and Management. For every surgical trainee out there, listen up. Getting this right isn't just important, it's literally everything. If you get this step wrong, nothing else you do for the patient is going to matter. So here's how we're going to break it down. First, we're going to establish exactly why A for airway is king of the castle. Then, we'll get into the specifics of how to spot an airway that's in trouble. After that, we'll look at the actual techniques for securing it. And to wrap things up, we'll cover the really critical differences when your patient is a child. It's a clear roadmap for mastering the very first and most important step. All right, let's jump right in. Part 1, the first priority. In the controlled chaos of a trauma bay, that ATLS mantra of X, A, B, C, D, E is our lifeline. It's our structure. But why does A for airway always come first? Well, the answer is pretty simple, and honestly, it's brutal. This right here, this is the fundamental truth of what we do, and the ATLS manual just says it perfectly. Airway patency alone does not ensure adequate ventilation, but without it, nothing else matters. Just think about that for a second. You can be the best in the world at stopping bleeding. You can stick a chest tube in, you can pump in blood, but if oxygen can't get into the lungs, it's game over. Your patient has absolutely no chance of survival. Okay, so we've established the priority. It's number one, no question. But how do you actually spot an airway that's in trouble? Or maybe even more importantly, one that's about to be in trouble? What are the red flags you're hunting for at the bedside? Now, this is where the theory hits the pavement. These are the hard, objective signs you've got to have on your radar. Massive facial fractures can just obliterate the bony structures, causing everything to collapse inward, especially when the patient's flat on their back. Bleeding into the airway, well, that's an absolute nightmare. And that last one on the list, trismus, that one is particularly nasty. Which brings us to this. Trismus is not just a fancy term you need to know for your exams. It's a real-life physical barrier. It's when the patient can't open their mouth, often because of jaw fractures. Now, just imagine what that means for you. It means you literally can't get your tools in. Your laryngoscope is useless. Spotting this early is so critical because it screams at you that your standard oral intubation is probably off the table, and you need to start thinking about a surgical airway, like right now. So the second you've identified a problem, there's no time to waste. You have to act, and you have to be decisive. And that brings us to our third section, actually securing the airway. Let's look at the whole spectrum of options you have. This slide really breaks it down into two main families of intervention. Over on the left, you've got your basic stuff, the simple jaw thrust, maybe popping in an oropharyngeal airway. Think of these as buying you time. They're temporary fixes that get you precious seconds or minutes. But on the right, you have the definitive airway, a cuffed tube in the trachea, period. This isn't about buying time anymore. This is about taking complete and total control. And knowing when to jump from one to the other, well, that's the art of trauma resuscitation. Now, let's say you're in a situation where you might need a surgical airway. You have to find your landmarks, and you have to find them fast, often by feel alone. The ATLS manual teaches this awesome little technique called the laryngeal handshake. It's a systematic way to know exactly where you are on the neck. You start up high on the hyoid, you slide down over that big lump of the thyroid cartilage, and your index finger will just naturally fall right into that little soft spot you're looking for, the cricothyroid membrane. Practice this on yourself, on your colleagues. You need that muscle memory for when things get really intense. Okay, for the gold standard, endotracheal intubation. It all boils down to these four critical phases. First, you prepare. Get all your gear ready and flood the patient with oxygen. Second, you intubate. Pass that tube right past the vocal cords. Third, and this part is absolutely non-negotiable, you inflate the cuff and verify your placement. The best way, the gold standard, is seeing sustained end-tidal CO2, and you have to back that up by listening for breath sounds on both sides. You never, ever skip verification. And finally, you secure that tube so it doesn't go anywhere. Prepare, intubate, verify, secure. It's simple, it's safe, and it saves lives. Right, so we've got the principles down for adults. But what happens when your patient is a child? Well, almost everything changes. And that takes us to our final and really crucial section, special considerations for pediatric patients. The goal is exactly the same, but the anatomy, that's a whole different ballgame. This table is fantastic because it lays out the key differences so clearly. First off, look at the tongue and epiglottis in a kid. They're huge in comparison to their mouth. This makes them super prone to obstruction. Then you have the larynx. It's not just smaller, it's located higher up in the neck and more toward the front, which makes getting a good view with your laryngoscope so much tougher. And the trachea is way shorter. This means your margin for error when placing the tube is tiny. It's incredibly easy to go too far and intubate only one lung. Every single one of these anatomical facts directly changes how you approach the procedure. So, knowing all that, how do we adjust our technique? Well, this slide shows us the practical moves. Because kids have such big heads relative to their bodies, you often need to put a little padding under their shoulders and back just to get their airway into a neutral, straight line. To deal with that big, floppy epiglottis, a straight laryngoscopy blade is often better because it lets you physically lift it out of your way. And here's a key update in recent years. We used to always use uncuffed tubes in kids, but now, cuffed tubes are considered totally fine, as long as you use the right size and you're carefully monitoring the pressure in that cuff. All right, we've covered a ton of ground. Let's make sure this last part really sticks. I'm giving you 30 seconds. What are those 3 key anatomical differences in a child's airway that make intubation so much harder? Got 'em? It's the relatively larger tongue and epiglottis, the more anterior and cephalad larynx, and that much shorter trachea. Knowing those differences, and more importantly, knowing how to adapt to them, that can literally make all the difference. That's all for this explainer on airway management. Stay sharp, and we'll see you for the next chapter.